This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from KRMC's Wallaby campus. Dr. Efren Cano is a board-certified family medicine physician. In June, he was named KRMC's Vice President of Primary Care. We'll talk with him about his work with patients and as a VP. Dr. Cano, welcome to the program.
Thank you very much.
Thank you. Thanks for fitting me in. I know, I get a sense that your days are super busy, so I'm grateful for the time.
Well, I appreciate for you having the interview with me.
Yeah, thank you. I said that you have recently been named the VP of Primary Care, and I do want to get into that. But first, my first question is, does administrative work take all your time now, or are you still seeing patients?
Very good question. And to answer that, it is in this role, myself and administration, we've had both requirements of that I continue with clinical practice. I became a physician to actually take care of patients, and I don't want to ever give that up. Mm-hmm. So my requirement was that I would continue, and so was administration. The CEO, Heath Evans, actually required that I continue seeing patients as well. So it doesn't take all my time. It takes a lot of my time, but I still see patients. I still am part of the residency program and the associate program director of that. And I still work at the nursing home and all of the other administrative stuff as well.
Yeah. Tell me about the importance of continuing the clinical side of your work.
The main reason why I got into this profession, of course, is to help people and to help take care of them and their health and their best and worst part of their lives. And I don't ever want to give that up. I want to continue to help people. I want to continue to see people. At the very beginning, I'm a family med doc. Yeah. At the very end, I'm a family med doc. I'm always going to be a family med doc. And I want to use those skills and to take care of people. Yeah. And so I will never give that up. I might bring it down to do some administration, but I will never give that up.
That's what keeps it real, right?
Oh, yes. I definitely want to see patients, and it makes me feel good when I go home.
Yeah. Well, let's talk about your role as a Vice President of Primary Care. For a general audience, what aspects of the hospital fall under the umbrella of primary care?
Okay, good question. So primary care for me is going to be our family medicine clinics, which will be the residency clinic, it'll be Mount Shadow, and it'll be Golden Valley. Primary care also includes pediatrics, so the Joshua Tree Pediatrics, and it also includes urgent care. So 5 clinics altogether.
And overseeing all those clinics and all those different people, what are your responsibilities? What do you have to do to keep them running?
In the primary care vice president role, my role is more to work on the clinical side with the providers and with the organization to help improve access, to help improve quality of patient care. So business-wise, I don't understand a lot of business because I did 12 years of schooling just for medicine. There's a whole component of medicine that includes administration and how to run the institution, the hospital, the billing, the coding, all of that. But that's why I work in concert with them, so we can make decisions together. In my opinion, it's a very intelligent way to try to improve care for our patients, because we have the clinical side where that is a component administration doesn't understand because they're not physicians, they're not providers, they're not in the room. So if they make a decision that's going to affect healthcare, how will that affect the provider to offer care for the patients?
I think I'm getting the overall picture here, and that is after many years of clinical work, you're now getting a different look at the books, at the fiscal realities of the job.
That is very correct. I am seeing a different component of medicine to where it impacts our patients in a bigger aspect that I've never really saw before. Mm-hmm. And I have an ability to help and shape primary care so that it offers better care for our patients. So cost is always a big deal. We always talk about the increasing costs of healthcare. Well, if business side is the only side that's working with this, and the clinical side's never involved with it, then decisions will affect the clinical side, and decisions will be made that may be detrimental to the care that you're giving, and they don't know because they're not physicians. At the same aspect, I may want the best, coolest looking medical equipment out there, but is that really better for the patient?
Yeah.
And so that's why we work together in concert.
You mentioned KRMC's CEO, Heath Evans.
Yes, sir.
I talked with him. It's been about a year now. I talked with him about the medical needs versus the fiscal needs. And are they always at odds? Are they often at odds? What is your perspective, given your position?
I love this question. The reason why is a lot of people think that there's adversaries between the clinical side and administrative side, the business side and the offering of medicine. And I like to take this at a different approach. I don't see it as an adversary. I see it as a partnership. Again, we need to be working in concert. So they understand an aspect of medicine that I do not. And I understand an aspect of medicine that they do not. If we work together and trying to, like, for instance, if I need a new equipment, I'm going to explain why I need the new equipment. They're going to explain the cost and everything behind it, and I'll get a better understanding of what they're looking for. So if it's going to offer better care for our patients, if I'm able to see more patients more effectively, then how do I communicate that to them in their language? At the end of the day, we're both looking out to have better care for our patients because we're here for the community.
If you'll pardon the pun, let's take the temperature of primary care. What are some of the specific challenges facing primary care here at KRMC?
All right. So the biggest one, the monkey in the room, the elephant in the room, however you want to say it, is going to be access. Access is big. Access as in how long does it take for someone to actually see a primary care physician? And that is one of our biggest challenges. How do we do that? In my role, it is to work with administration to try to not only figure out how do we get more providers here, but also how do we look outside the box and figure out how to increase access with the limitations that we have right now. So is there ways that we can see patients differently? Is there things that we can do to change how we see patients? Will that increase the number of patients that can be seen during the day? So that is one of our biggest things that we have.
What goes into studying that, crunching those numbers, researching with other groups? What goes into trying to improve that efficiency and that reach of services?
So we take a look at not only how we're doing it now, but we also take a look at how other people do it. We're not an island all by ourselves with primary care. The nation has been doing it. There are strategies out there that different organizations have done that we can look and we can mimic it and we can improve healthcare by looking at that. So it is taking a look at what we're doing here, taking a look at what has been successful in other places, and how can we incorporate that in our organization and how we do it right here. And some of the things we've been doing quite successfully, and hopefully we're going to improve on other things that we do with primary care right now.
Mojave County locals may kind of lose perspective on, because it takes them a while to see a doc, there is a nationwide provider shortage going on. Can you give a little insight on that?
Yes, that is correct. If I remember the numbers correctly, nationwide, I think it's stating that will be a shortage of primary care docs, about 124,000 providers by the year 2034, I believe. And Arizona itself will be shortage of about 2,000 providers. And the big portion of those providers in our rural areas, especially Mojave County. So it is our job to try to figure out how to, with that in mind, those numbers in mind, how to improve healthcare, improve access, knowing that that's where we're going. And to me, I find that exciting. It's exciting to try to look outside of the box and try to figure out things that we can do in concert with administration to try to improve our healthcare and improve our access here.
Yeah. Speaking of that nationwide provider shortage, we could get way beyond the scope of this program trying to untangle that Gordian knot. But there are a whole lot of factors, as I understand, that go into that, such as a population living to be older, greater states of chronic disease, What else am I missing? Fewer specialists?
There are fewer physicians going into primary care. There are fewer primary care docs being developed, if you will. Residency is the type of education that you have out of medical school. There are fewer of them out there with the growing population. So, there are a lot of shortages of physicians and physicians to come with our retiring physician age out there as well.
Yeah. Physicians make a good living. They work hard. They train super hard. They give up much of their lives. The things that normal folks enjoy, many of those are off limits for physicians. So having said that, physicians make a good living. But family medicine docs and pediatricians are on the low end of the pay scale. Not asking for anybody's sympathy, just pointing out that they're on the low end of the scale. And you said these are areas specifically of family docs, right?
Yes, this is correct. Yes.
So you have a young doc who's just coming out of medical school who wants to go into residency, and he or she may be thinking, I'm going to become a surgeon. I'm going to become this subspecialist. That's where the money is. Meanwhile, we still need family practice docs.
And there's another component of that you're also missing too, and that is the student loan factor as well. To become a physician is incredibly expensive. Averages anywhere from $250,000 to $500,000 to become a physician, and to pay off those loans is extraordinary, especially with a primary care physician who is, you're correct, on the lower end of the pay scale for all physicians.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week my guest is Dr. Efren Cano. He is a family practice doc, and he's the Vice President of Primary Care here at KRMC. So if I have your permission, what went into your decision to make family medicine your specialty?
When I first started, like in medical school, and I'm looking at what type of specialties I wanted to do, I've always wanted to do family medicine. It's always been on my radar. The money in itself on how much I'm going to be in debt and how much I will be making really never came into a factor. I'm not going to be uncomfortable financially. I'll be comfortable. Am I going to be the general surgeon or the cardiothoracic surgeon that's driving around in a nice car? No, I'm not. But that's not why I went into medicine. I went into medicine to take care of people. And my job is to not only take care of people, but try to figure out ways and options to improve all of these, if you will, risk factors for becoming a physician. And those are the challenges that I have also been tasked with, and I kind of find it exciting. How do I attract more physicians to primary care? Big part of it is I'm also part of the residency clinic. And residency, for people that don't know, is after medical school. So let's say I'll go real quickly in how to become a physician. So you go to college, you get your undergraduate degree, and then you go to medical school. Medical school is 4 years. You graduate medical school, yay, you're a doctor. You're really a doctor of nothing. You have to go into further training to become the type of doctor that you want to be. That's called a residency. We actually have 2 residencies in KRMC. We have a family medicine residency and we have an ER residency. A residency trains physicians to become board certified in their specialty. So I am the associate program director for our residency program here. So part of my roles and responsibilities is also to help physicians come in to be trained in our residency, so that way we're also part of making primary care physicians, family medicine physicians. And I'm excited about that. A lot of our providers that we have here are graduates of our residency. Matter of fact, I'm a graduate of our residency.
You are. I wanted to talk with you about that.
Yes, I am. It's been about a decade or so, but yes, I graduated from this residency right here in Kingman.
The time flies. Part of what a lot of hospitals like KRMC are doing with their residency programs is trying to attract young docs who might like to stick around afterward. And then it worked in your case.
Yes, sir.
What went into that decision for you to stay here at KRMC?
The biggest reason for me staying in Kingman. One is I fell in love with the community. I fell in love with the medicine here. I was trained here, being familiar with the system here, being familiar with the medical records here, the electronic medical records. That's the dictation and charting that we have here. Familiar with the doctors here. Familiar with the community.
Can you take a phone call from?
I apologize.
Please.
Yes. Okay. Other reasons for staying for KRMC besides the love of the community itself and the familiarity of the hospital system is I am an Arizona boy. I was raised in Arizona. Wasn't born here, but I was raised here as a little baby. I didn't really want to leave Arizona. So on that aspect, I love the weather, Kingman. I love the community here. I didn't really want to leave. But furthermore, how do I do that to attract more physicians here? Because Kingman is a very small community, and it's hard to attract physicians, as everybody knows. So some of the things we do is our resources at KRMC, our institution here is actually a very, very good institution. I think we have one of the best healthcare institutions here. I do think we need to improve on it and make it even better than what it is. And so we use that to attract the physicians here. The weather here, it's just gorgeous.
Perfect. Yeah.
Right. As for the community and the patients here, you fall in love with the patients and you want to take care of them. And I just don't see how someone could take care of people and not love the community here. We've got a lot of great things here.
The landscape is always changing, and you have to stay on top of it.
Oh, yes, that is true.
So, Doc, I know that you're well acquainted with the residency program here in many respects. And just to kind of finish up that conversation on the residency program for now, when you meet a young doc and someone who's just coming in and starting, what is your pitch for KRMC? How do you say, hey, we want to look for people who will give this place a chance and really, it worked for me, I want it to work for you. What's your pitch?
The pitch is the training that they receive here is, I put it in par with some of the best places out there. I just think the training that we have in a very rural area and to be able to learn with the type of healthcare opportunities they have, the departments that KRMC has, the types of patients that we have. When young physicians take a look at this, they really get excited and want to learn here and become a family practice physician that when they graduate here, they can go anywhere, practice any type of primary care that they want, and hit the ground running without really having any sort of hesitation. And that makes it very attractive for a lot of young physicians.
We've talked about some of the challenges facing medically underserved areas. KRMC and Mojave County count as medically underserved. And this is a topic that's come up in some recent interviews because I've been talking with some of the good folks from KRMC Counseling Services, which I understand is growing. They have a lot of good folks there. So here's my setup. For years, we would do the community health survey, and again, we would see this need for mental health services and addiction services, and those two so often go together. And I know that this is something that the hospital has made great strides in. Can you talk about that a little bit?
Yes, of course I can. So what you're talking about is the behavioral health integration. So primary care deals a lot with psychiatric services, so depression, anxiety, and psychiatry is far and in between. We don't have a whole lot of psychiatry resources. And so we have to figure out what do we do because a lot of primary care's time is dealing with psychiatric services. So we've partnered with behavioral health integration. So basically it is counselors in our office that we can refer patients to at the time of need during the visit, and they can acutely take care of patients, do some counseling. We on the medical side can offer the medical support, the medications, and then if needed, they can actually help the patient get into a psychiatric service, like for instance, other long-term counseling or long-term psychiatric care.
Are the stories coming back to you where you're finding that this is really making a difference in the community?
Oh, yes, 100%. It is, the patients are really appreciative of the fact that when they come in here and they don't know where else to go, and I see it, mostly I like to see it from the older males. They don't think that counseling has anything to do with them, have not really thought about it. They come in and I'm able to offer a lot more resources than just saying, hey, here's a pill for this. And they're very appreciative of that. And every one of them that comes back and I have follow-ups, they're very appreciative that they're able to talk to somebody in our clinic. They don't have to go anywhere else, any other building. For family-wise, they can just come to the clinic. They're going to the doctor's office and they're having counseling services here. It's been a wonderful service that we have for our patients.
Older males in particular, there is such a cultural bias against
There is.
Mental health problems. If they get hurt physically, they might go to the doctor. They might not do that either.
Right.
But certainly for mental anguish, they historically have not.
Yeah, there is such a negative connotation with psychiatric services. But in my world in medicine, it really is just another disease that we have to take care of, and we can. And I'm excited that we have services here in our clinic to help with all of our patients, not just the older males, but everybody of all ages, even children.
Well, Dr. Cano, I am very grateful for your time today. And in the moment that we have left, I'm going to let you get back to work. But in the moment we have left, I wonder if you could say a little bit about what is ahead for KRMC Primary Care.
Wonderful, wonderful. So ahead for primary care, access. Of course, we're looking to get more physicians, more providers. It's not just physicians. There's physician assistants. There's nurse practitioners as well, and try to incorporate them into primary care, but also how we use all of the resources that we have, the providers. I am trying to put together, not put together. It is a process that's already involved. It's called teams-based approach, to where you typically would think about, you go to your doctor and you see your primary care doc and you get treated by your one doc, and then that's it. But it makes it difficult when you don't have that many docs. One of the ways I'm trying to think out of the box, and it's already been done, I'm not reinventing the wheel, is teams-based approach, where the clinic, the institution, works as a team. So the patient has access to the whole team, not just one provider. And this helps the patient to be able to be seen sooner. It's not just with one provider, it's with the whole team, and specifically on what the patient needs. So if those needs of that day is a simple diabetic check, does that really need the physician, or are there other services within our office that the patient can be seen and taken care of? Those are the exciting, out-of-the-box thinking that we are starting. And it's not just me. This is, like I said, I work in concert with administration. I work with a whole team to try to think outside of the box and bring these new, innovative opportunities. Other things is healthcare has barely tapped telehealth type of visits. We're looking into that as well. How can we bring it here? What can we do? Is this a possibility? Other aspects is population health. It may be a little bit of a complicated subject, but I will try to explain it a little easier for everybody to understand. Population health is looking at our community as a whole population and treating the population as a whole and not an individual person itself. Let's say I have a population of females that need mammograms to check for breast cancer. The only way we do it now is if I see about 20, 25 patients a day, I can only do it 25 patients a day at a time. That's so inefficient for a population of all Kingman. Is there a way that I could look at the whole population, identify all the females that qualify and are in need of mammograms, and order them all together? There is. That's called population health. And we are starting this type of innovative program to look at how do you do this. And again, not reinventing the wheel. These things have already been done. We're just trying to integrate it into our facility here.
That is Dr. Efren Cano. He is a family medicine doc, and he is the Vice President of Primary Care here at KRMC. Dr. Cano, thank you so much for your time today.
I appreciate everything. Thank you so much for the questions.
And that is the program. That's Focus on Your Health. I'm T.G. Lafredo, and thank you for listening. Stay healthy, and we'll catch you next time.